for the virtual U Miami Health Talk. Tonight's topic is Your Eye Health is Number One, What You Need to Know. It's brought to you, of course, by Bascom Palmer Eye Institute, the nation's #1 eye hospital. I am your moderator for this evening, health journalist Ileana Bravo, and Bascom Palmer Eye Institute's experts want you to know that they are ready to care for you. You can do it in their clinics or virtually, wherever you are. We'd also like to mention tonight that our speakers are available for all these patient visits, either in office at the 5 Florida locations for Bascom Palmer, or of course by virtual visit from the comfort of your home, because at the end of the day, they're there for you. We invite you to learn also more about the safety measures we have in place to keep you safe when you come into our clinics, as well as your appointment scheduling options, and you should visit bascompalmer.org to learn more details about that. Well, tonight we're very excited. We're going to hear from 3 internationally known ophthalmology experts from the Bascom Palmer Eye Institute. Each of our panelists will speak on a different eye health topic and answer your questions. Dr. Zubair Ansari will be speaking about cataracts, the leading cause of worldwide visual impairment and blindness, impacting 20.5 million Americans aged 40 years and older. Dr. Jacqueline Kovac will speak about age-related macular degeneration, or AMD, which is a common and debilitating disease where genetics play a vital role and risk. Dr. Swaroop Swaminathan will discuss glaucoma, a family of more than 30 diseases that affect pressure within the eye and damage the optic nerve. After each panelist presentation, we will poll the audience on questions relevant to the discussion. So we invite you to be interactive, be involved, answer the questions. They are multiple choice, and you will be able to participate. Also, there will be a question and answer session at the end of all the physicians' presentations, and we're going to do our best to answer as many questions as we can. We have hundreds of you joining us tonight, so that is very exciting to get you informed and educated. Some of you have submitted the questions in advance, but if you haven't, there's plenty of time. You look at the anonymous Q&A feature at the bottom of your Zoom screen, the little boxes that have 2 bubbles, thought bubbles, and that's where you put in your questions, and we will screen and field them and give them to our presenters tonight. So I am pleased to begin with our first presenter, Dr. Zubair Ansari, who's an assistant professor of clinical ophthalmology at Bascom Palmer Eye Institute. He's a comprehensive ophthalmologist who specializes in general eye care and cataracts. Following medical school, Dr. Ansari completed his residency at Bascom Palmer, followed by a fellowship in academic global ophthalmology at the Wills Eye Hospital in Philadelphia. Of course, we're very excited that he returned to Miami and to Bascom Palmer, where in addition to treating patients, he works to combat the growing prevalence of blindness and visual impairment in underserved communities. He coordinates volunteer training for Bascom Palmer's residents and works with charitable institutions, doctors, and scientists to provide humanitarian, surgical, and medical aid around the world. This evening, Dr. Ansari will speak on cataracts and some of the many intraocular lens replacement options that are available to those who may require cataract surgery. We welcome you this evening, Dr. Ansari.
Thank you so much for that wonderful introduction, Ileana. Happy to be able to talk today. It's truly an honor and a privilege to talk about a subject that's near and dear to my heart, and that is cataracts and how we can combat global blindness by eradicating cataract blindness. As Ileana said, I am a assistant professor at Bascom Palmer and the medical director of our outreach program and global ophthalmology program as well. I have no financial disclosures related to this talk, and I want to say that all the photos of the patients that are displayed in this presentation were taken with verbal or written consent. So first, sort of stepping back, I think it's important to describe or sort of characterize the scope of the problem that we have around the world. Unfortunately, there are 2.2 billion people that are estimated by the World Health Organization to be visually impaired worldwide. And when we take further analysis of that 2.2 billion, what we find is that nearly 50% of those patients tend to have visual impairment, which is considered to be avoidable in the form of needing glasses or cataract surgery or detecting early glaucoma. And again, if we do a further analysis of that 50%, what we find is that the vast majority of that impairment is secondary or due to cataract blindness. Unfortunately, we think that we're doing a good job, but the numbers are against us in so many different ways. The rate of blindness and visual impairment is only postulated to increase into the 2030s. So when we look at specifically bilateral cataract blindness, it's estimated that that number or that value is expected to double by the time we hit 2030. Now, why do we care about cataracts? What is it about cataracts that puts us at increased harm and at increased risk? Well, there have been numerous studies that have shown that obviously those who suffer from cataracts put themselves at harm when it comes to driving cars in the highway. We also know that cataracts can be a cause for falls in the elderly and needless hospitalizations. But lastly, and probably most importantly, what we know now is that numerous studies have shown that depression levels and activities of daily living are sometimes hindered by the fact that someone might have a cataract in their eye. So stepping back a little bit further, what exactly is a cataract? I mean, we hear a lot about it, but what exactly does that mean? When we look at a schematic or a anatomy of the human eye, what we can see is that there are sort of three major structures that we look at. First, the cornea, which is the clear tissue that light first hits when it hits the eye, and then in the back of the eye we have the retina and the optic nerve. But in between those two structures is a vital organ called the lens. And when we're born, that lens is crystal clear. But as time ages or as a cataract develops, that lens can sometimes be opacified or whitened or brunescent and can sometimes interfere with light entering into the eye. Here is a clinical photograph showing you exactly what a cataract looks like from a bird's eye view. In this patient's right eye, you can see that there is a white opacity that is present in that eye, and that is actually a cataract and a significant cataract in this patient. In the left eye, you can see that there is no opacity, and that's what we consider to being a normal lens. There are a number of symptoms that we look at when we talk about cataracts and what they can cause in the eye or cause in our subjective vision. The most common complaint that patients describe is a film or a haze over their vision, and you can see that by the schematic here on the top left photo. Another common complaint that patients may describe is having halos or glare when it comes to night driving or oncoming traffic, a very common complaint that we hear about when it comes to visually significant cataracts. The top right photo is actually a photo by the famous French impressionist Claude Monet at his later life, in his later years, drawing out water lilies. And you can see here that the artist's rendition of the water lilies at the time that he was affected by cataracts shows an incredible distortion and brunescence to his later images. What are oftentimes the risk factors that we look at when we determine if a patient is at increased risk for developing a cataract? I had a mentor in medical school once tell me that cataracts are unfortunately due to getting wiser and being unlucky. So we do know that increased age is a risk factor for developing a cataract, but we also know that there are a number of chronic diseases in the way of diabetes that can cause it. Any history to trauma in the eyes can certainly cause it. Any type of surgery or surgical intervention that has been done previously in and around the eye puts you at higher risk for developing one. And long-term steroid use. So many of our rheumatological patients or those who suffer from rheumatological disease, inflammatory bowel disease that necessitates IV steroids at some point in the lives puts you at a slightly increased risk for developing a cataract. Unfortunately, at this time, there are no medicines or pills that can resolve a cataract. Cataracts can be cured by surgical interventions. Fortunately, through the advent of a number of increased techniques and intraocular lenses, the surgery has been widely used and is the most common procedure performed worldwide and can be done with very minimal risks and complications to the patients. The basic gist of cataract surgery is we make microincisions either by hand or by a laser and enter into the eye. We can then use ultrasonic energy to break up the cataract into tiny fragments. Those fragments are then aspirated out of the eye, and then using the lens as scaffold, we're able to inject intraocular lenses that are specific to that patient into the eye. I want to go briefly into the lens choices for you, the patient, as over the last 10 to 15 years, we've seen an advent of intraocular lenses that can be very beneficial in recuperating patients' vision. Remember, lens choices are customizable. So lens choices to you may be very different from your neighbor or your friends. Lenses now have the ability to correct for astigmatism or bends of shapes of the cornea. It also has the ability now to correct for presbyopia or near vision difficulties for patients. Oftentimes when we decide on a lens choice, these choices should be made in conjunction with your ophthalmologist or cataract surgeon, who is sort of gauging your eye individually and determining what is best suited for your needs. So let's go through some of the considerations before the cataract surgery. Before cataract surgery, you should have a preoperative appointment with your ophthalmologist. They should look at your eyes after dilation, check your eyes for glasses, and obtain the relevant imaging studies that they need to decide what kind of lens or what kind of cataract surgery is best suited for your eye. There should be some discussion about intraocular lenses, as I mentioned. And of course, unfortunately, there are complications to every surgical procedure done on the human body. Again, cataract surgery tends to have rare complications, but it's important that your cataract surgeon describes for you those types of complications. We may ask our patient to undergo some medical clearance as well if there's any medical situations that we're concerned of. And then oftentimes we have patients on a regimen of eye drops before and after the procedure. So we often ask patients to purchase those eye drops from their local pharmacies. On the day of the procedure, the day of the cataract surgery, I like to describe cataract surgery as a Thanksgiving dinner. So the length, the highest length or the time of your procedure is actually before the procedure and after the procedure, the preparation and the cleanup, so to speak, after cataract surgery. Again, cataract surgery is a same-day surgical procedure. So usually their patients come in and they leave the same day. It's done under local anesthesia with some IV sedation and IV supplementation if need be. And again, the actual length of cataract surgery typically is pretty fast, averaging about 15 minutes, 30 minutes on the high side. After cataract surgery, it'll be important for an eye care specialist, either the cataract surgeon or optometrist, to take a look at the eye to make sure it's recovering in the way that we like it. Recovery can sometimes be variable based on the patient's eye. I typically like to say about 3 to 7 days for us to achieve sort of improvement into vision. And then oftentimes there'll be some adjustment with drops in the immediate post-operative period as well. Now, when is the best time to consider cataract surgery? So cataract surgery, really the timing for cataract surgery depends on you, the patient. We as ophthalmologists look for certain signs, but the most important thing is to discuss with you what your symptoms are. If you're unable to drive or you're having difficulties with sort of falls, we may decide that cataract surgery is more necessary sooner rather than later. And in terms of having that dialogue with your ophthalmologist in terms of timing is very important. And remember, cataracts are a progressive loss of vision. Folks typically don't lose their vision acutely from cataracts. So if there is a loss of vision suddenly, there may be something else that's going on in the eye that we need to be taking a look at before cataract surgery. What do you do if you have cataracts? Well, call us at Bascom Palmer. We're very happy to schedule you for cataracts. We have an excellent cadre of cataract doctors that can take care of you. Of course, discuss with your ophthalmologist and even your primary care doctor some symptoms that you might be having. It's important to have an ongoing dialogue with your surgeon and pick a surgeon that you're comfortable with that will be able to walk you through the cataract preoperative process. And remember, Bascom Palmer has a 24-hour emergency room. So if you have sudden loss of vision or significant pain, those are typically not signs or symptoms of cataracts. And we would ask you to come to our emergency room if you exhibit those sort of symptoms. Now, a frequent question that we get asked at Bascom Palmer is, what is Bascom Palmer doing to adjust to COVID-19? Obviously, it's thrown us all for a loop, but we at Bascom Palmer have been doing our very best to adhere to social distancing and the best practices to be able to provide the best possible patient care to you and to be safe as well. We have a negative pressure room that we've been able to screen and take care of COVID-positive patients with acute ocular complaints. Our 24-hour emergency room is still open. All of our surgical patients get tested for COVID-19, and we're also on the precipices and the cutting edge of implementing novel technologies to be able to take care of you. Lastly, I'll leave you sort of with my baby, and that is global ophthalmology and medical research or medical outreach. We at Bascom Palmer are making incredible strides and are continuing to try to make incredible strides to reduce those large numbers I discussed at the beginning of the talk in terms of preventing people from going blind and addressing cataract blindness in low resource environments. So we're hoping to continue to kick those off with our vision van and some of our many global partners and global outreaches. But we need your support more than ever in these times to be able to take care of this burgeoning problem in terms of cataract blindness and any preventable vision loss. So thank you so much for your time and your attention today. It's been a pleasure to be able to talk on this subject, and I can't wait to answer your questions.
Thank you, Dr. Ansari. And there are so many questions indeed, and we appreciate that our expert providers are actually going in the Q&A box and answering some directly. So here's our first poll question. Have you or a family member ever had an eye condition that made daily activities difficult or impossible for an extended time? It's a yes or no question. So all of you in the audience out there, get your buttons ready and answer this question if you would kindly for us. Our first poll question, have you or a family member ever had an eye condition that made daily activities difficult or impossible for an extended time? Yes or no? And shortly we are going to hear from our next presenter, Dr. Jacqueline Kovac. And we have almost a split decision, but 57% of the audience says yes and 43% say no. So that sets us up basically for to whom are we speaking? So our next presenter is Dr. Jacqueline Kovac, an associate professor of clinical ophthalmology at Bascom. She specializes in retina and vitreous diseases, which include age-related macular degeneration and diabetic retinopathy. She's created a clinical trial center at Bascom Palmer in Naples, where she currently sees patients. A recipient of the Exceptional Women in Medicine Award, she's the author of Luminaries, Profiles of Women in Academic Medicine, which profiles 24 outstanding physicians and scientists at the University of Miami Miller School of Medicine. Tonight, Dr. Kovac will discuss macular degeneration, of which we have so many questions coming in, its current treatments, as well as treatments now in clinical trials. Dr. Kovac, please take it away.
Thank you so much, Ileana, for that kind introduction. Good evening, everyone. It's such a pleasure to be with you all virtually this evening and discuss a clinical and research interest of mine, age-related macular degeneration, or AMD as we call it. So this lecture is going to be a broad stroke overview of what AMD is and our current available treatments and investigational treatments. And when I say investigational treatments, I mean treatments that are currently making their way through the 3 phases of human clinical trials in hopeful anticipation that they'll receive ultimate FDA approval. So clinical trials are really the process by which new drugs are developed and tested. And they're research studies that explore whether a treatment is safe and efficacious in humans. It's evidence-based medicine. So the purpose of clinical trials is research. So the studies follow strict scientific standards. And the drug development process begins in the lab. If the drug looks promising, then it proceeds to animal trials and then to human trials. The first phase of human clinical trials involves a small number of patients. You're really looking at safety. Phase 2, it's a larger number of patients. Phase 3, it could be hundreds to thousands of patients. And you're really comparing the new drug, the investigational drug, versus standard of care. Is this better than what we currently can offer our patients? So a few years ago, I started a clinical trial center at Bascom Palmer at Naples to be able to offer these new treatments to our patients who wouldn't otherwise be able to receive them since they're not yet clinically available. I also wanted to play a role in bringing new drugs to market and, of course, help the greater good. So age-related macular degeneration is the most common cause of irreversible blindness in the developed world, and unfortunately, it affects over 10 million Americans. And it compromises our central vision. It can cause blurriness, distortion, dark areas in the central vision. But even the patient with the most advanced state of AMD will always have their peripheral vision, so they'll never see total darkness, but we need our central vision to read and drive and perform a variety of activities in our daily lives that we need to do and that we enjoy. So quick crash course on ocular anatomy, just to review. On the right, light enters through the cornea, where it's focused by the cornea and then the lens onto the retina, which is this orange structure that lines the inside back portion of the eye, kind of like wallpaper. The retina is made up of highly specialized, irreplaceable nerve cells, essentially, that their job is to convert light energy to electrical energy that's then taken to the brain via the optic nerve and interpreted as images. When a retina specialist looks in your eye, this is what they see. On the photograph on the left, the optic nerve here, the retinal blood vessels, and the orangey tissue of the retina that's bounded by those blood vessels, that's the macular portion of the retina that provides our central vision. If we take a piece of macular retinal tissue and look at it under the microscope, this is what we see. Light sensing cells, the photoreceptors, their support cells, and underlying blood vessels. In dry age-related macular degeneration, drusen form, and these are little yellow deposits under the retina composed of inflammatory cells and cholesterol, and ultimately that leads to just poor function of the overlying retinal tissue and poor central vision. In wet macular degeneration, you get the development of abnormal blood vessels in and under the retina that shouldn't be there. And they leak and bleed, and if left unchecked, they form a scar and poor central vision as well. So how do we diagnose AMD? Well, there's no lab test. There's no good genetic test even. It's really a clinical diagnosis. Your retina specialist looking at your macula and finding drusen of a certain size, number, and distribution, and then we make the clinical diagnosis of age-related macular degeneration. In patients that have advanced dry macular degeneration, they have something called geographic atrophy, and that's what we see here, this lightish area in the macula where there's really no healthy retinal tissue, and this area appears dark on this image. Optical coherence tomography is the imaging modality depicted here. This enables us to see an optical biopsy, really, of the macula, all of the 10 layers of the retina. This is the most sensitive and specific way to diagnose macular degeneration, and this test is performed on all of our macular degeneration patients every single time they come to the office. And this is what drusen look like on our OCT imaging, these little excrescences, these little lumpy, bumpy formations under the retina. And this is what atrophy looks like, disorganization of the retinal cells. What about wet AMD? Well, wet AMD, although accounting for only 10% of AMD cases, accounts for the majority of vision loss from age-related macular degeneration. And in contrast to dry AMD that progresses in a very slow way, and some patients may have early AMD and no symptoms at all and not even know they have the disease, wet AMD can cause sudden changes in vision, sudden new distortions, sudden new blind spots, sudden new central blurry vision. And we ask all of our patients that have AMD if they ever notice these changes to come to the clinic urgently so we can diagnose and treat them and maximize their visual outcome. This is a photograph of the retina of a patient who has wet AMD, and the new blood vessels that are abnormal that we don't like are here. And this is the blood leaking out of them under the retina. This is the OCT image. You see these abnormal blood vessels here, and these dark crescentic areas is fluid leaking out that shouldn't be there as well. So what are the risk factors for AMD? Well, age is the most powerful risk factor. AMD is only found in folks over 50. So if you're diagnosed with AMD and you're under 50, it's likely a misdiagnosis. Age is the most powerful risk factor. In terms of environmental risk factors, smoking is the most powerful risk factor, and then also genetics and systemic inflammation. AMD is a strongly hereditary disease. I've been fortunate to participate in a fruitful collaboration with our human genomics department here at UM for the past 12 years. We've actually recruited over 1,200 patients into our genetic AMD studies just at our Naples office. And we've really been able to push the needle forward in terms of our knowledge base of genetic risk factors for AMD. We've been able to identify over 50 genes that affect AMD risk. But we still have a lot to learn. We need to learn more about how these genetic risk factors play a role in progression of AMD and also in treatment response. What about treatment for AMD? Well, there's no great treatment for dry AMD. AMD, as you remember, is an incurable disease. So first off, I recommend that all of my patients with AMD live as healthy a lifestyle as possible, that they eat a healthy diet, a Mediterranean diet, they take a daily multivitamin, regular exercise, of course, avoid smoking, and I recommend that they all take the age-related eye disease study 2 AREDS supported vitamin formulation, which has been proven in thousands of patients to slow the progression to advanced AMD. At Naples, we're also involved in a clinical trial called the OAKS trial, which tests a new drug for patients with advanced dry AMD, since we have no treatment for that other than vitamins. The drug's called APL-2. It's developed by the Apellis company. It's given to patients injected in the eye every month or two in the hopes that it will be able to slow the progression of advanced AMD better than the vitamins. So stay tuned. The results will be out in a year or two. This schematic shows all of the drugs currently in the clinical trial pipeline for dry AMD. There are a lot. We're all working really hard to solve this problem. These drugs some are directed to protecting retinal cells, their support cells, suppressing inflammation, and also gene therapy. So I think the future is bright for us to find better treatments for dry AMD. Now, what about wet AMD? Well, prior to 2005, the treatments that we could offer were laser, hot laser, also called focal laser, or cold laser photodynamic therapy, but neither offered visual acuity improvement. At best, it was vision stabilization, and not too infrequently, patients lost vision from the laser treatment. So in 2005, my mentor at Bascom Palmer, Phil Rosenfeld, pioneered the use of Avastin, a drug that's injected into the eye for the treatment of wet AMD. It belongs to a class of medications called anti-VEGF inhibitors, basically a drug that blocks vascular endothelial growth factor, VEGF, which promotes blood vessel growth. Since that time, Lucentis and Eylea have been FDA approved to treat wet AMD as well. They're all injected into the eye. They're all anti-VEGF agents. And the cartoon on the left shows a schematic of angiogenesis, which is new blood vessel formation, which is something we want to stop in wet AMD. And on the right, we see Lucentis here in blue, grabbing the vascular endothelial growth factor protein, preventing it from binding to its receptor, and furthering the progression of new blood vessel formation. Let's quickly talk about a case. This is a 61-year-old gentleman with wet AMD in the left eye. Best corrected visual acuity is 20/70. And you can see initially the blood vessel complex here and fluid, this black area under the retina. Initial visual acuity, as I said, 20/70. After a series of Avastin injections and then Lucentis, you can see the decrease in size of these blood vessel complex, elimination of fluid, and the patient's vision improved to 20/20. About 30 to 40% of patients that have wet AMD treated with anti-VEGF agents experience a visual acuity improvement, and about 90% have stabilization of vision. So our number one goal, of course, is to maximize visual acuity with the fewest number of injections possible. Anti-VEGF therapy is chronic therapy, so patients need anywhere from an injection every 4 weeks to every 10 weeks, kind of long term. There are 3 treatment strategies. The most commonly used strategy is treat and extend, where you do an injection every 4 weeks until the macula is without fluid, and then you kind of increase that interval as much as the eye allows. So the recipe for maximizing vision using anti-VEGF therapy for wet AMD, early detection is key. Drug selection should be a decision between the patient and the treating physician, and early and frequent individualized treatment to keep that macula fluid-free. This is a schematic of all of the drugs in the clinical trial pipeline to treat wet AMD. These are basically, most of them, next generation VEGF blockers, but there's also gene therapy and a couple other pathways that are being looked at. So very exciting. So just a few take-home points for you. AMD is a common and potentially debilitating condition, and we know that genetics plays a very important role in AMD risk. Right now, AREDS vitamins and anti-VEGF therapy are the standard of care for the management of dry and wet AMD, respectively. And clinical trials offer great potential for better treatments for AMD. I want to thank you all very much for your attention, and I look forward to answering your questions. Thank you.
Thank you very much, Dr. Kovac. And we're moving right along to our next poll question, which again, we ask our audience to kindly answer and give us an idea. Would you consider enrolling in a clinical trial to address an eye condition like AMD? Yes or no? Would you, of the hundreds out there in the audience tonight, would you consider enrolling in a clinical trial to address an eye condition like AMD? Yes or no? And while we're waiting for everyone to answer, please remember that we have the Q&A feature at the bottom of your Zoom screen, those two little dialog boxes, and we encourage you to enter your questions. If we can't get to them live, our expert providers tonight are answering them one-on-one directly in some cases. So it is a wonderful forum for you to get educated. So would you consider enrolling in a clinical trial? 60% said yes. Only 40% of the audience declined. So that's a great result. All right, so now we are going to go to our final speaker of the evening, Dr. Swaroop Swaminathan, an assistant professor of clinical ophthalmology at Bascom Palmer. After completing his residency here at Bascom, Dr. Swaminathan completed additional fellowship training in glaucoma at the Duke Eye Center. He specializes in glaucoma and enjoys working with patients to identify optimal treatment options for the disease, including newer, minimally invasive glaucoma surgeries, commonly known as MIGS. He has established a glaucoma imaging research laboratory at Bascom Palmer to improve the technologies used to diagnose and monitor glaucoma and to research novel imaging techniques to help identify high-risk patients. Dr. Swaminathan will speak with you about glaucoma, its early signs and symptoms, risk factors, and current available treatments. Welcome, Dr. Swaminathan.
Thank you so much, Ileana. Thank you to you all for joining us this evening, and hope it's been a great educational experience for everybody. I can say I've definitely learned quite a bit from Dr. Ansari and Dr. Kovac's presentations, and hopefully this will build a little bit on what we've been talking about. So the title of my talk is Glaucoma, the Silent Thief of Sight. Some of you may have heard of that phrase before, and we'll get right into it. So what is glaucoma? Many of you have been asking on the Q&A about individuals who you know who have glaucoma, family members who have glaucoma. So I borrowed this beautiful schematic also, like Dr. Ansari, to show us what parts of the eye are affected in this disease process. So glaucoma is a process that causes painless vision loss, and it's due to damage to the optic nerve. So as Dr. Kovac explained beautifully before, the retina is a key part of the eye that provides input from the outside world. And those fibers that are produced from the retina then go into the optic nerve, which serves as a cable that connects the eye to the brain. And it basically allows the brain to see and perceive images. Now, the key thing here is that glaucoma is typically painless, and so evaluation by an eye provider is really, really important to make sure that we catch this in its early stages if present. Now, it's very, very prevalent, so it affects over 6 million Americans, and even more so among specific communities, especially in the African American community and the Latin communities here in the US. So what's abnormal in glaucoma? So the optic nerve, remember, is that cable that connects the eye to the brain. So here on the left, we have an example of an optic nerve that's normal and healthy. And we can notice here the nice pink orange tissue that runs around in the periphery and a small cup. And what we're referring to when we say that is this inside kind of donut area where there's no actual fiber tissue. It's kind of an opening. And you'll notice here in the normal that this cup area is actually quite small. And we have very healthy pink orange tissue in the periphery. Now let's compare that now to the image on the right, which is an optic nerve that has pretty significant glaucoma. So you'll notice the difference here with the cup being much, much larger. And we can see here that the rim tissue, again, those are the fibers. Those fibers are really quite significantly damaged. And there's really not as much here as you would see in a normal eye on the left image. So what happens to individuals who have glaucoma? So here we have an individual who perhaps is looking out onto the street and looking at some traffic. And as this individual starts to develop glaucoma, their vision loss begins in the periphery. So here we have an image in the on the right where you can see that this person, has a general sense of what's going on in this road, but some parts of it are a little blurred out. Here on the right, a little bit on top. And unfortunately, as the disease continues to progress, if untreated, this process will eventually work its way towards the center. And so you can see here in more advanced glaucoma that the individual is really only able to see the center portion of the image and really is unable to appreciate the peripheral stuff. And as an important aside to what Dr. Ansari said, you know, he mentioned the fact that cataracts can cause blindness, it can cause falls, or car accidents. And this is also an important thing when it comes to glaucoma. You can imagine that if you're in a car and you have severe glaucoma, it's very dangerous to be driving when you don't have very good peripheral vision and you're trying to go through an intersection, for example. And of course, if this glaucoma, again, is untreated and remains unaccounted for, this central vision will slowly diminish over time and ultimately can cause blindness. So it's very, very important to make sure you get treated. So what are the risk factors? So most certainly, as with the other disease processes that were discussed tonight, advanced age is definitely a risk factor. As I mentioned before, race and ethnicities are risk factors as well. So in the African American and as well as the Afro-Caribbean communities and Latin communities, these individuals are 4 to 5 times more likely to actually develop glaucoma. So definitely very important to make sure that these processes are monitored in these populations. Most certainly family history. Many of you on the Q&A were asking about this. Most certainly, if you have a family history of glaucoma, definitely important to get checked. Dr. Ansari mentioned the cornea before. So remember, the cornea is the clear outer portion of the eye. And when those corneas are thinner, that in general also increases one's risk for glaucoma. And then finally, the most important one, because it's the only modifiable risk factor, is high eye pressure, or elevated eye pressure. And again, I bolded this one because this is, again, the only modifiable risk factor. We can't really change the thickness of our corneas. We unfortunately can't change our family history, and we can't change our age or race, ethnicity. Those are things that, of course, we're born with. But this is something that we can change, meaning we can work on trying to reduce our eye pressure. But I will add the caveat, and this is important, that eye pressure isn't always the culprit. There are plenty of patients who have something we call ocular hypertension, where the pressure in the eye is high, but these patients actually have a very healthy optic nerve and they don't tend to develop damage. So that can happen in some patients. And on the flip side, we also can see patients who have normal eye pressures, meaning it's in the normal range, which is usually what we say below 21 millimeters of mercury. And these patients, even though they have quote unquote normal pressures, actually can develop optic nerve damage and glaucoma. So again, the bottom line key message, as you've been hearing through all of our presentations, that screening and coming in for an eye provider appointment is very, very important to make sure we don't miss these important processes. I wanted to take a quick aside to discuss something which I see quite commonly in clinic, and that's specifically patients who, let's say, go to a local eye clinic or an optician and they are told that they have narrow angles. And patients are often referred into my practice as well as many of my colleagues to evaluate them for narrow angles. So I just wanted to help you understand what that means. And so that's related to the drainage angle in the eye where the fluid is leaving the eye. So there's, again, an inherent fluid that's produced in the eye. That's kind of what you can think of as kind of like an air in a basketball. It helps keep the eye inflated. And so this fluid is produced by this tissue right here that's labeled the ciliary body. And the fluid follows the path of these blue arrows. And so it kind of comes out into the front portion of the eye, and then it exits in this angle right through this tissue that's black, labeled the trabecular meshwork. Now, in an eye that's been labeled as narrow angle, what that refers to is that this drainage area where the fluid is trying to leave the eye isn't as accessible. So perhaps the way the eye is built, the anatomy of the eye, that the iris, which is the colored portion of our eye that we usually see in each other, that this iris is kind of almost occluding or preventing the fluid from getting into that drainage angle. And that sometimes can cause the pressure to be high as well. Now, the reason why it's so important and the reason why individuals and patients are often sent in to the ophthalmologist or the optometrist office for further evaluation is because if this is untreated, this can really cause a pretty severe event, which is often referred to as an acute angle closure attack. And I just included an image of what that might appear as, where the eye is often very red, the eye is hurting, the vision gets blurry, and the pressure in the eye is very, very high. Again, because the fluid that's produced in the eye doesn't have an exit route. And so this is something that is an ocular emergency. And as Dr. Ansari mentioned, we have our emergency room at Bascom Palmer that's open 24 hours a day. And this is not an uncommon presentation that we see there. So coming back to, in general, therapeutics for glaucoma, how do we treat glaucoma? So you'll remember the only main modifiable risk factor is elevated eye pressure. And so we work on treating glaucoma by lowering the pressure. So what are some non-surgical therapies, non-surgical treatments? So our mainstay, usually the first line therapy, includes drops to the eye, as well as sometimes pills. And these are a whole host. They often have various cap colors, and we often refer to them by the cap colors with our patients, as you can see in this image here. And the goal with these medications, the drops, as well as the pills, are to basically try to reduce the production of the fluid. So you can almost think of glaucoma kind of like an issue where you have a sink, and you have the tap that's open and the drain that's not really working too well. And so the goal with these drops are to try and reduce the amount of fluid that's being produced in the eye. So trying to kind of turn down the tap in the sink. And so the main focus of these drops are to try and reduce production, and some of them also try to increase outflow. So you can think they're almost trying to pour a little Drano down that kitchen sink. Now, in addition to that, we're very excited to also start offering this new novel therapy to our patients. This was just approved a few weeks ago by the FDA, and that is an injectable medication that can actually be placed in the front part of the eye. It contains a small pellet, and as you can see here, compared to the size of a US dime, it's quite small. And this device contains medication on it. And so the medication elutes, it kind of diffuses into the eye while it's present over the course of 4 to 6 months. And it's really a great option that I'm very excited about offering our patients, because this can try to reduce the burden of medications and having patients having to remember to put drops in their eye. And so this is an exciting therapeutic that we now have in our armamentarium as glaucoma specialists. And in addition to these two options, also laser therapy is something that we are able to offer our patients with glaucoma. And that ultimately is usually to enhance the outflow. So what we're doing here, as shown in this little schematic, is to apply a laser to the natural drain system to help that drain system work a little bit better and get the pressure down and the fluid out of the eye. Now, I included here a mention about narrow angles. So again, we talked about the narrow angles and the problem there being that the fluid doesn't have access or as good access to that drain system. And in that condition, when we apply a laser, we're actually applying a laser to try and open that angle and try to allow the fluid to exit. And that's a laser that is applied to the iris in order to make a small hole in order to, again, allow the fluid to access its draining system. Now, what happens if patients are unable to tolerate these medications, or if their pressure still remains above what we need it to be? Then we need to think about surgical options. And so surgical treatments include, I would say, kind of categorize them into two groups. The first is what we refer to, again, as Ileana very, very appropriately named MIGS, which is minimally invasive glaucoma surgeries. And these surgeries are really, I again, try to use the analogy of Drano. It's kind of the idea of trying to put something to try and help the natural drain system work better. And so the goal here is to use things like a stent, as you can see in this graphic, to try and open up the natural drain system. We sometimes also use an actual blade to try and open up the drainage system as well and help the pressure get down. Another analogy to think about this is kind of what we see in the cardiac world. And so if some of you have had relatives or individuals that you know who had heart problems or had a heart blockage in one of their blood vessels, they're often either a candidate for a stent or they may need a bypass. And so this is kind of like a stent that you would put inside one of those vessels to help things work better. That is in contrast to a quote unquote bypass procedure. So in the eye with glaucoma, we have our own version of a bypass, and that involves putting in, for example, a tube device, which is implanted on the outside of the eyeball. And then a tube is inserted into the front part of the eye, and it provides an alternate pathway for the fluid in the eye to get out and to help us keep the pressure in the eye down, and thus to maintain vision for our patients. Now, similar to our prior presentations, I just wanted to comment on something that has very much come up even in our clinics, and most certainly I'm sure many of you are wondering about, and that's how do I manage, going to appointments, or should I be going in? to see providers right now in the context of our pandemic. And so, if you are a patient or you know somebody who has glaucoma and they're not sure about coming in, I think it's really important, to understand this is a nuanced issue. It's dependent on many things. It's dependent on the degree of the disease. It depends on how advanced the glaucoma is. If you are, or that person is someone who has had recent surgery, more likely than not, you probably need to be going in to make sure things are going okay and the surgery is working appropriately. And so it's really dependent on a few issues. The other thing I'd like to put in context as well is that, glaucoma is typically a chronic kind of gradual condition. Not, again, not every case, but in general, it is a condition that doesn't necessarily happen overnight. But it's something that takes time to actually cause damage. So, oftentimes I get phone calls or messages from patients who are very, very anxious and very concerned, that they had to delay their appointment by 2 or 3 weeks. In general, as I mentioned, usually that's not an issue. But again, the key thing here is making sure that you are in constant conversation with your provider in order to determine the most appropriate follow-up period for yourself. And the other thing that, again, Ileana touched on in the beginning, which is a great point. All of us at Bascom Palmer are very excited to offer both telemedicine, audio, visual appointments with our patients, as well as hybrid visits. Hybrid visits are this great version of appointments that we're really excited to offer our patients, where patients can come in, get some testing done, and they can go home, and they don't necessarily need to stay at our facility necessarily to see the provider, and the provider can follow up with them via video or phone at a later point to discuss the results. And so, this is a great option for many of our ophthalmology appointments. In glaucoma, it's a little more nuanced, again, because it is an asymptomatic, usually, disease. And so I like to just say that I think for us in this specific area, it can really be used as a starting point to start the conversation with your provider and then determine when it's appropriate to come in for formal exams and formal testing. And again, as I pointed out, conversation with your provider is really, really essential. So with that, just again, wanted to summarize, glaucoma is typically an asymptomatic disease. And so for that reason alone, screening is really, really important to make sure that you come in and you are going in for your annual eye exams with your local provider, especially if you have certain risk factors, family members with glaucoma, if you're from certain communities that have a higher risk. It would be really important to make sure that you get screened. And all of us are extremely excited to see you here at the Bascom Palmer Eye Institute. Again, as mentioned, we have plenty of satellites where we're excited to see our patients and ready to do so in a safe manner. And so with that, just want to say thank you. And I think we'll hand it back to Ileana.
Thank you, Dr. Swaminathan, indeed. And we're going to swiftly go through our final poll question, so get your fingers ready to vote. Have you delayed eye screenings, care, or procedures because of the COVID-19 pandemic? Please answer yes or no if you've delayed eye screenings or eye care, any procedures because of COVID-19. And we're going to quickly get through this, and then we're going to begin the Q&A because, boy, do we have lots of questions to answer. So let's get results on this poll. And 67%, that's encouraging, doctors, that they have not delayed. 67% of our audience have not delayed screenings or eye care, but 33% have. And so we'd like to put that aside. So let's start with our first question, and that is going to go to Dr. Swaminathan. Are there any existing treatments that can regenerate the optic nerve?
That's a really great question, and it's one definitely that I get from patients quite frequently in clinic. And unfortunately, there's still a lot of research going on in order to help us understand whether that is possible. But as you can imagine, when you have a cable that's connected to a part of our brain that's mapped out to understand where in our space are we seeing things and how does it correspond to depth, you can, I'm sure, appreciate that it's a very, very complex issue, and it's very, very difficult for us to be able to do so. So short answer is there's a lot of research going on, but as of right now, unfortunately, we do not have those options.
Okay, this question goes to Dr. Ansari, and it's sort of a twofold one that I'm going to toss at you because it's sort of related. Why do both eyes usually develop cataracts instead of just one eye? And the second part of that question is cataract surgery possible when a patient has AMD?
Yeah, so excellent questions to both. So the answer to the first question is, remember that the eyes don't sit in isolation with the human body. They're very much connected to what's going on from a systemic point of view and from a genetic point of view. So typically when someone develops a cataract in one eye, they're predisposed to having sort of the same milieu to develop a cataract in the other eye. Refractively also, if a patient has a high prescription, for example, in one eye and we plan to do cataract surgery, sometimes that other eye may need surgery because patients aren't able to tolerate a high difference in prescription. So that's sometimes our considerations in doing both eyes pretty rapidly after one after the other. Now, regards to AMD, and Dr. Kovac can maybe back me up on this as well, but when it comes to dry AMD, there's been numerous studies that have actually shown that by performing cataract surgery, even just by improving a patient's subjective vision, might be beneficial to be able to help the patient in terms of their activities of daily living. Now, in wet AMD, I believe that it's probably best to work in conjunction with the retinologist to be able to relieve or alleviate some of the fluid and some of the treatments that she described prior to moving towards cataract surgery. But I believe Dr. Kovac can adequately address that.
That's absolutely right, Dr. Ansari. You know, it's certainly fine for patients with dry age-related macular degeneration as long as you can prove that there's probably going to be a benefit to doing it. In patients with wet macular degeneration, you definitely want to make sure that that's well controlled with anti-VEGF therapy and that the macula is fluid-free before you proceed with cataract surgery. Great question.
Dr. Kovac, now I will tee one up for you, so stay on screen. I have a family history of both macular degeneration and glaucoma. I'm 55, my eyes are healthy, I get annual exams. Are there things I can do from a preventative perspective? And I see a lot of the questions coming on about vitamins and supplements, so maybe you can sort of encompass it all in one.
Right, so I mentioned the AREDS 2 vitamin formulation in my talk is something that I recommend for all of my AMD patients. Unfortunately, there's no proof that this is preventative, so I don't recommend that patients necessarily take this if they don't have AMD. If they just have a family history and no signs of AMD, they can certainly take it if they want. There's no harm, but there's no proven benefit either. And like I mentioned in my talk, you know, living a healthy lifestyle goes a really long way. Mediterranean diet, not smoking, regular exercise, a multivitamin, and of course, annual checkups.
Okay, here's one that I've heard from friends who have actually done this. Are there pros and cons in cataract surgery to have one eye done for nearsightedness and one for farsightedness versus having both eyes for near and wear glasses for reading?
Yeah, great question, Ileana, and certainly a question I get a lot in my clinic as well. So what you're describing is a technique called monovision, the idea that one eye could be targeted for distance, one eye could be targeted for near, and it's actually an excellent option for some patients. The considerations that we use to decide if a patient is worthy of that is, again, looking at the overall health of the eye, making sure that both eyes can function normally, and seeing if the patient may undergo what we call a monovision trial. So sometimes we can place a contact lens over the eye to decide if they're able to tolerate that difference. And most patients are able to do that. So yes, that's a great consideration. And then again, we gauge the patient's symptoms and their goals of care. For those avid sort of drivers and golfers, we might just decide that balancing the eyes for distance is the way to go. For those who have kind of lived their life reading books or being on their iPads and cell phones, sometimes we might target those eyes for distance or for near. So it really depends on the conversation that we have for a patient, if that's an option.
Okay, I'm going to keep throwing these out here and we're going to grab them and go with them. Can double vision develop with eye problems?
Yeah, I mean, so I guess I can tackle this one. There's any number of eye problems that can cause double vision. A patient having an acute sort of complaint of double vision definitely needs to be evaluated in a very acute basis, as a number of strokes and lesions can cause double vision. So the short answer to that is yes. And obviously, and Dr. Swaroop can comment more on this, but any patient who has suffered sort of complete vision loss as a result of glaucoma can sometimes see deviations of the eye as well.
Yeah, absolutely. Just a quick answer or response to that is most certainly, there are surgical, uh, uh, procedures that we do in glaucoma that can sometimes cause diplopia or double vision. That's something that, often is temporary and can be resolved. And if not, can be surgically evaluated as well.
Here's one that I think people are going to look for: signs and symptoms of high eye pressure that would signal the need for screening.
Yeah, so as I mentioned in my slides, unfortunately, pressures unfortunately that are just slightly high, but not extremely high, are not necessarily perceived. We don't necessarily feel them. So that's the real reason to make sure that you're going in for your annual exam, your eye checkups with your local provider, and everybody who is well trained as an optometrist or ophthalmologist usually is aware to look for these conditions such as glaucoma or high eye pressure. And they'll be able to refer those patients to a glaucoma specialist for further evaluation. But it is asymptomatic, and so that's why it's important to be screened.
This one seems like a benign question, but another common thing that people complain about: how to address dry eye other than using sustained drops once or twice a day and things like that.
Yeah, as a comprehensive ophthalmologist, I think this makes up the bulk of my practice, and actually probably makes the bulk of all of our practices, the idea that dry eye can sometimes be exacerbated by these conditions. And so, yes, there are a number of options out now in the market that can be suited for patients with dry eye, and we're beginning to learn more about the mechanisms that are at play when it comes to dry eye. And so sometimes we tailor dry eye treatments based on the mechanism of the dry eye for the patient. So I generally like to tell my patients that dry eye is a chronic condition. It sometimes takes 2, 3, maybe 4 visits for us to get it right and to try to find the correct stew, if you will, to be able to take care of and alleviate the patient's dry eye.
Dr. Kovac, I'm not sure if you answered this offline privately, but this question came over. Please comment on the complications with the use of Beovu, am I saying that right? For AMD injections as vascular occlusion.
So Beovu or brolucizumab is another anti-VEGF agent, kind of similar to Avastin, Lucentis, and Eylea. That's new. It was newly FDA approved October 7th, I believe, last fall. And the whole retina community was so excited about this drug because the clinical trial results were really encouraging. However, there were patients in the clinical trial who had developed, few patients who developed low-level intraocular inflammation. When we started to use Beovu in a real-world experience outside of the clinical trials, we still saw cases of patients who had developed inflammation in the eye after Beovu. And so most of the retinal community, including myself, have really paused on the use of Beovu. The Novartis company who developed the drug has been very helpful in leading a global investigation, trying to figure out what about the Beovu protein is causing the inflammation. So stay tuned. Hopefully they can modify the drug, make it a safer alternative to what we have now.
Thank you, Dr. Kovac. And many of you are also asking on the Q&A area how to get a telemedicine appointment. Stay with us. At the end, we're going to put up all those numbers and all that contact information again so that you can do that. Meantime, how about this question? Does elevated pressure in the eye cause sudden pain in the eye? Is that a symptom?
Yeah, great question. So again, in general, an elevated pressure tends to not cause pain. The only exception, which is important to be aware of, is what I'd mentioned with regards to narrow angles and what we talked about, which is an acute angle closure attack. And so in that situation, typically patients, as I mentioned, have a red eye, their vision gets suddenly blurry in one eye, not the other. They kind of get maybe a headache, a throbbing sensation. And again, that's due to the fact that there's a mechanical occlusion of the natural drain system in the eye, where the fluid in the eye that's being produced has nowhere to go. And so it's just a fluid buildup. And so that causes inflammation, irritation, et cetera. So in that case, yes, one can develop sudden onset pain and should be evaluated emergently. But again, on the whole, it is not necessarily something that can be felt with pain. And so again, good screenings are important.
Dr. Swaminathan, this question came, I think, specifically for you. What is Amsler grid?
I think probably most likely for Dr. Kovac, so I will let her answer that question.
Thank you so much. So an Amsler grid is basically a grid, a big square with little squares in it, lined with straight lines. And we ask our patients with more advanced dry macular degeneration and wet macular degeneration to use this grid to try to identify worsening of existing wet macular degeneration or new wet macular degeneration by noticing any new dark areas in the vision or distorted lines. So we ask our patients to look at this grid, to kind of keep it on the refrigerator, keep it handy, look at it every day, one eye at a time, just to look for any new changes in their vision.
We're going to wrap it up soon, but I'm going to throw these out there because this person just asked a couple minutes ago, can you correct astigmatism with cataract surgery? And then I'll throw this one out there too, so that you can, whoever wants to tackle, does an irregularly shaped cornea affect the cataract removal outcome?
Yeah, so both are actually pretty similar question. Astigmatism by definition essentially means that there is a bend to the shape of the cornea. Sometimes that bend can be regular and sometimes that bend can be irregular. For patients with regular astigmatism, yes, we do now have a number of available lenses that we can place at the time of surgery to orient in a proper axis by which we can correct, if not all, but maybe the majority of the patient's astigmatism. So yes to the answer for regular astigmatism. For irregular astigmatism, sometimes those toric options or those astigmatism correcting options may be contraindicated. We oftentimes get a number of images, but one of the images we obtain is a topographical map of the eye to see if a patient is worthy or can deserve a toric lens to correct that astigmatism.
Well, thank you to all three of our incredible providers at Bascom Palmer. World-class medicine. People trust you. We thank everyone for tuning in tonight, the hundreds of you who were there. Our panelists, Dr. Ansari, Swaminathan, Dr. Kovac, thank you so much for being with us this evening. We tried to get to all of your excellent questions. And again, our providers did a really good job of trying to answer them directly and privately. But we at the University of Miami Health System and Bascom Palmer Eye Institute really appreciate you trusting us and being here, because we are here to care for you. So please visit bascompalmer.org to learn more about the topics covered or to make a virtual or in-person appointment with our experts. And please also complete the survey at the end of this so you can give us some feedback and even give us some topics for the future that might be of interest to you. Thank you to all of our panelists. Bravo, great job. Appreciate you taking the time, and to all of us in the audience. Please have a great night and stay safe, everyone out there. Good night.
Good night. Thank you so much.
Thank you.
Thank you. Good night.